So my presentation is a joint work with Canan Desai, a scientist at NCI, that she has been doing a lot of work in some of the points that I will provide you today. And as well, I had the privilege to have the comments on some of our maps from Julian Marshall, who is an engineer, environmental engineer at the University of Washington, and who has been very reactive to my demands about how we could move to better spaces when we are in a consultation. So yesterday, it was presented already, this slide. This is a preprint paper by Pierre, and he indicated this is a work that has been done in the US, I think it's in Chicago, where they use all the mobile phones and they trace the movements and they identify the places where clusters could occur more frequently or more with a higher likelihood, and they identify that restaurants were the places where the risk was higher. But I brought back this slide because if you see the offices of physicians, they don't have a low risk. It's not among the lowest ones. So when visiting the scientists, we might have a risk, and that's what we have to take into account. This data comes from high-income countries, and I am wondering what would be the risk of acquiring an infection when we go to any clinical center in some places around the world. Going as well to the comment that Alex asked in the previous session about what is the excess COVID risk, when we do an intervention. There's this beautiful paper by Abbas in the Lancet this year, in which they compare the deaths averted by vaccination, and they compare it with an estimated excess deaths due to a COVID infection. And they evaluated the beta ratio, benefit risk ratio, and you can see it's always positive. Particularly vaccinating against measles it has a major advantage, and overall one would say by vaccinating we really do much more benefit than harm. But as we know, screening for cancer has been delayed and stopped, as it has been presented throughout the sessions. And here is data from the US for breast cancer, colon cancer, and cervical cancer from 39 health systems in 23 states. So what's going to happen. It was very, very nicely presented by Emily, and I take a copy of her graphs in her paper, and you can see that while now we are diminishing the number of cases that we are detecting, we will see an increase that will be higher if women have been screened with cytology as compared to, in the yellow bar, as compared by using HPV. But we don't know exactly what is the risk when we call people to come to our clinics. And I am always trying to think in low and middle income countries where crowdness is sometimes impossible to control. And what can we do? So we do believe that it's important to go back, although we don't have yet this risk ratio estimation, but we think that the introduction of the vaccines, even if they are now promising results, are going to take at least 1 or 2 years at minimum to reach everybody. So we have to try to return with certain conditions to a regular screening activity. And with Canon and the group at NCI, we recently published a small paper proposing the design of COVID-adapted screening strategy that would involve these 6 pillars, no? Risk-based prioritization, efficient screening methods, physical redesign of the clinics, social distancing measures in the clinics, hygienic measures in the clinics, and COVID testing. And I will just go over these pillars very briefly. As you know, not everybody has the same risk to die of cervical cancer. So maybe a risk-based prioritization is going to be key at this moment. And obviously the people in the red background should really be managed as soon as possible, and followed by the women that have some kind of abnormal result. And then maybe the next one would be people with no history of screening, and that because these women are really a much higher risk of developing cervical cancer. And finally, when things are a bit clear, go to repeat screening for HPV negative women. Obviously, with things always trying to introduce HPV screening because it's the only way we can do massive screening in low and middle income countries. We based our results on this prioritization because we have evidence that the progression of precancer is slow. So, and as well, women that had been screening with HPV, they have a very good long-term negative predictive value. And this takes the point of Eduardo before. No, I think the difference in the models that were presented before is because when you do co-testing, what is the advantage is mainly that you are introducing HPV testing, and this gives a very long predictive negative value. How to go back again, how we can facilitate the screening. Self-sampling is going to be key. We do believe very much that it's the only way to go in low and middle resource settings to introduce massively screening because it's the only way that, that you can avoid physical examination. We know that the screening can be done at home or in clinics, but avoiding touching the woman or the woman touching the medical team. It is generally it is very well accepted if there is good enough education. There is high accuracy, and Mark Carving has produced a beautiful work showing that it can be very highly accurate, and even more if we use a PCR test. And then we have to guarantee that we follow up those that they are positive, so not to abandon these women. This is always a key issue in low resource settings, and it can be as well recommended all over the world. It is very good to see that many organizations are now moving towards this concept, and I am very, very pleased to see that WHO in their recent publication, updated of their publication about practices during emergencies, they include the promotion of self-sampling for HPV testing, promote online advice after a negative test, use a single visit approach if possible, and prioritize as well women living with HIV. So that's very good news that WHO has been fast in introducing these concepts. About designing the clinics, we have been working with a group in Nigeria, Dr. Ajani Fuja, this is the real map of his clinic, and you can see they have open windows that they didn't have. They add exhaust fans, and they have a circuit that goes from the outdoor waiting area. The person enters and goes to the registration desk, and then it goes to the colposcopy exam. So it is important that there is no air conditioning if the rooms are closed. Windows and doors in the clinic rooms to be kept open all the time, and fan running at at highest speed. This is very important. And to permit the entry and exit of fresh air. That's very important. And electric exhaust fans to direct the airflow out and away from patients and clinicians. This seems very logical, but it's not always taken into account. And you see that there is as well the advice of the unidirectional flow of patient, and that was what we consulted with Julian Marshall, and he approved our recommendations. Sorry. When you cannot have a building, it's as well an option. Yesterday we heard about mobile vans, but we can use containers. I think in South Africa, Lynn Denny has been an expert in using containers for screening on cervical cancer. We can use that, open big windows, and try to do the same strategy as it is in the building office. Just one thing that has been, and I put here because you can go into this website, this person has contributed to an amazing amount of models that you can see how the airflow is important. And here he has two experiments in which he measures CO2 as a correlate of viral particles. And when he's outdoors, he enters into the room where his wife was working, and then she leaves, and the CO2 vanishes slowly due to the filtration of the air. But if he does the same and opens partially the window, the removal of CO2 goes much faster. And so it just shows the impact of in 2 hours of opening and having a room ventilation, opening a window. So important as well to have the measures that many countries follow well, but not everybody, which is the social distancing. Advertise well, no walk-ins in the clinics, one person at a time. Make sure that there is alerts so that people can come and understand that there is no companions in the examination rooms to avoid overcrowding, and as well restricting the staff to absolutely essential workers. Hygienic measures, it's important to use a mask, as you can hear from all over. N95 seem to be preferable. Clean the surface regularly and as common as possible. Obviously, hand washing all the time as much as you can, and put all the signs that are appropriate in all the places, so that people can feel as well that they go to a place that it's taking care of the potential infection, and that they will be more comfortable in coming to have the visit. I just wanted to tell you that surgical masks may have, and I saw some of you using them in the Zoom, the air is expired outside if there is an opening from the edges. And so it is very important not to sit behind someone who wears a surgical mask like that. So be aware that not everybody uses well the masks, and that N95 is a bit safer than this one. And as well, there is a big thing that we understand now that by talking or shouting, we really increase the risk of contamination of the air. And as well, if we stay talking with some friends, even if we are 2 meters apart, after 4 hours, let's say for a lunch in which we are all separated, all the room, unless it's ventilated, even if we wear a mask, will be a lot of particles. So the fact of talking, it generates a lot of particles. So that needs to be taken into account when you go to visit the doctor, when you have patients at your clinic. So the last part is COVID screening and testing. Obviously, we have basic secure measures of screening people, whether they have fever or sore throat or even cough. So when these symptoms are present, a person should not be entered into the routine care and manage them adequately as a potential COVID case. It would be great to have a rapid and sensitive test for detection of the virus. There are many tests now in the market that they are competing and being evaluated. There are three groups of tests: the PCR, which is the most accurate but is expensive and needs high technology expertise. And there is not, to our knowledge, a point of care test available. There is an isothermal amplification based COVID test that is rapid. It's a bit comparable. It's the technology that is being used with Unfire. It's rapid and could be done directly with saliva. It requires little training, is affordable, relatively affordable. It's not very expensive, but it still needs a lot of pipeting. The platforms are expensive, and our data suggests that they are not yet at the level of sensitivity that we would like to have. And as well, there is the third group of tests, that they are the rapid antigen tests, that they are strip-based, and still the data is not yet performing as we would like. We do think that when we have this testing, that I hope it will come at any day, it will be a change in the field, because if we can really measure who is infected, who in our team can have every day a single test and just make sure that they are not positive, and any person coming to the clinic can be tested, that would be really great, as they try to do when people take a flight in many companies. No? So to conclude, I think it's very important that we measure the benefits against the harms. And if we are not sure about that, or we think that we are not able to provide a secure environment, delay screenings, delay the screening. COVID-safe options, obviously, it adds a cost, because we have to change many gloves and change space, and we cannot have the same throughput of visits. But I think it's worth to invest on this, so that we can restart activity, at least for priority groups. Campaigns for massive screening in low and middle income countries, it's our opinion that they should be delayed at this time, and that health teams can use this waiting time. There were some programs that they were going to start due to some big grants, that have been available, trying to move towards this elimination campaign. But probably it's better to hold for a year and trying to improve the logistics, work on the scenarios of every day, and try to make sure that when people come to the clinics or to the centers devoted to screening, they can do it feeling that they are safe, and that we offer them some protection. And with this, I finish. I'm happy to receive any question.